And you're off mute.
Okay, hi, good afternoon, everyone. Thank you for coming at the end of the day. So, not standing in the drink line just yet. I'm Jess Quiring. I live in Albuquerque, New Mexico, and I'm the Oncology, Navigation, and Outreach Manager for New Mexico Cancer Center. I help with patient support, education, clinical and community connections. We're a standalone privately owned physician practice, the last standing in New Mexico, probably one of the last standing in the Southwest, actually. So we have expanded our practice outside of oncology. We now have pulmonary care, primary care. We just added a sleep lab. We have a ENT. We're collectively becoming a very multidisciplinary practice. So we have a lot of physicians on staff and advanced practitioners. We are still primarily an oncology practice, so that is still our main focus. And we do all treatments in our cancer center except for surgical procedures, which we're also starting to do those too because we now have a surgeon on staff. But we don't do, I guess one of the only things we don't do these days is blood transfusions. So the things I'm going to talk about are primarily cancer-based because that's the setting I work in, but they're really things that you can transition over to any clinical practice or organization that's focusing on patients and how to engage and activate them and what that means. Like a lot of people who work in this field or become advocates or work in cancer, I have my own personal story. I am a cancer widow. I lost my first husband to a rare terminal cancer that's now not terminal. When he was 36, I was 34, and we had 2 small children, and we experienced advocates and navigation, having to travel for care, having to figure out how to pay for it, how are we going to pay our mortgage at the same time, who was going to help us with that, how are we going to get there, on and on and on. You guys know, you do this every day. So after he passed away, he wasn't alive very long after his diagnosis, I went back to school and educated myself on cancer and became an epidemiologist and staging person, tumor registrar. And then, but my passion was in navigation. So I'm very fortunate I became a navigator. So, and I'm going to cover like a broad view of programming and how you can engage your patients in the community or in your clinic through programming. And then my colleague Dani is going to do more of the direct patient care, how she does activation engagement and direct patient care. We both work in direct patient care and also run programming. So, but I'm going to do the programming side. So, patient engagement and activation. So, historically speaking, when you think about patients and are they engaged and activated, like that's a pretty passive thought or static. There's not been a lot of thought about it. Considering how the patient is experiencing the care they receive is a pretty new concept, actually. We haven't really historically thought about it. And only about a third of patients report that they feel confident enough to understand the care they're receiving or have control over the care they're receiving, which is a sad statistic considering how complicated our healthcare system is and the payment methods and how they're focusing on the patient experience, like with value-based care, CMS's pilot programs. It's a pretty big deal to have your patient have a good experience and their perception of the quality of care they're receiving as well. So an engaged and activated patient has a better sense of autonomy for themselves. They're better able to make decisions about their care, and they're better able to adhere to any healthcare plans or treatment plans they're given. And an engaged and activated patient will help the system with keeping costs down, help your facility keep your costs down, and help the patient keep their own costs down. So how do you do that, and what does it look like? So this is the definition of patient engagement. So it's anything you're doing to help activate your patient into their care, and any of the interactions that they encounter along the way, including like, how does your organization or clinic answer the phone when the patient calls? And then activation is the patient's ability to take what they know, what you're telling them, and turn it into a skill to help themselves throughout their own care and empower them to be a part of their own care. So here's some engagement and activation activities with patient engagement. In engagement, the patient's actively participating in their care. They're not passively sitting there. You're helping them to activate and engage through what they're doing, whether it could be telling them how when they call, this is what's going to happen, these are the questions we're going to ask you. That's helping them to be engaged in their care. And you want to be patient-centric, right? You want to try to make your processes surround the patient. Our clinics and doctors like to make the processes surround the clinic and the doctor, what the doctor needs. So trying to think about it more about how can I make the patient the center of this cycle, and focus, and also make sure we're addressing what the doctor needs, but that the patient is the primary stakeholder. And that takes an operational shift, right? That takes a whole structural shift, actually, trying to get doctors and systems to think differently than how they're used to thinking to address those things, but to get them to think about the patient first. And in addressing the patient's care, all these other things will also get addressed. That the information you're providing them to the patient is meaningful to them, not just to your system and your practices and the doctor, but it's meaningful information to the patient and their family. It's something they can understand and follow through with. And you're including their family. It's not just the patient, but their team. Their family's a part of the team, and having that team-based approach, and the patient and the families and the team and the advocate, whoever is part of the care team, you're all one team. And the meaningful connections that you can make to, if your particular clinic or organization doesn't have everything there in one location, that's okay. But what can you do to bridge that gap and have it be more meaningful for the patient? And they're still tied to your clinic, and see you as the spoke, that hub of the wheel, while you connect them to all the other things, even if it's outside of your organization. And then the activation side is your patient's experience of these engagements, and it's directly related to their health outcomes, how they experience those things, how they perceive what you're trying to do for them, helps them feel better about coming to get their dialysis done or get their chemotherapy, whatever it is you need them to do. It helps them feel better about it. They're more likely to do what you say and adhere to it, because that also forms trust, and they feel like you're steering them in the right direction and you're going to help them take care of it. They're also more likely to talk about what they need because they are experiencing you in a different way and the system in a different way. And they'll have a higher quality of their life perception, even if it's end of life care. They're still going to have a higher sense of quality of life and a higher satisfaction of your services, which is good for them because it all ties back to their psychological well-being of how they're experiencing their care. And that also ties back to your Medicare surveys and how your practice is being paid. So why does your clinic or organization care about this? Because it still ties back to their return on investment for them, in addition to how their patient feels about receiving their care back there. And they're going to have a broader ability to manage any health directive you give them and follow instructions, because you know, it's when they're overwhelmed, it's hard to get them to follow instructions. Sometimes they become so overwhelmed they stop doing everything, including calling you or coming to their appointments. You have to figure out why and why that's happening. Where do they need help with that? And sometimes it's just that they became overwhelmed and no one could hear or see that. So, oops, this clicker goes backwards. So there we go. Right away, you can start your engagement the minute a family or patient walks through your door. You can use inclusive signs, you can use welcoming signs that show that your organization or practice welcomes everyone, that this is a safe space for them to be who they are, and that you're open to everyone who comes in the door. And also use language that asks them who they are, who are they as individuals, not just checking the boxes that we check in our demographic EMRs, but having the patient tell you who they are. This is a wonderful, these are all tools from George Washington Cancer Institute, by the way. They do some wonderful inclusivity tools that you can brand for yourself, and they're all free. But the tool on the right, the questionnaire, if you have a staff member use that, you want that person to have training and diversity and inclusion, and not just give it to a staff member who doesn't know how to help a patient fill this out in a meaningful and appropriate way. And then you want to make sure you're culturally competent. Who are the people you're serving? What are their cultural backgrounds? What is meaningful to them in care? What's important to them in their healthcare? What's important to you in your healthcare may not be what's important to them in their healthcare. What may matter? Who are the decision makers in that group? Is it the person you're talking to? If they're Navajo, which is practice from where I'm from, the elders aren't making the decisions. The younger generation begins to make the decisions for the elders, which is a difficult shift for us sometimes. It can feel like the patient's not being heard or being respected or doesn't know or isn't part of the decision making. Well, it's just a cultural shift. Understanding that they're still included, but they're not the ones who are going to look at you and make the decision. So are you having a cultural approach to talking with your patient and the care they need? And are you adapting your information you're sharing with them and your population to meet their needs? And also check the boxes you have to check, because we all have qualities that we have to meet, standards of care we have to meet, but we want to make sure it's meaningful to the patient. And be aware of the cultural barriers, like, is the elder making the decision? Or should you even be looking at the patient directly with your eyes? What does that mean for them? Check your own biases. Is what you're talking about matter to you, or are you coming from a place that matters to the patient and their family? And using appropriate engagement materials. Dani is going to show the NCCN tool in her slides in a little bit. I thought about clicking to it, but it's way too many slides, so I'm not going to do that. But this is just the NCCN psychosocial distress screening for oncology care, and you're able to adapt that. So this is the adaptable version that we created to meet the needs of our Navajo patient families. So we changed the language to be third person, not first person, because if you speak in first person, you're speaking something onto someone, and we don't want to do that in their spiritual faith. We want to speak, this sometimes happens, come alongside the person rather than speaking something at them that could be speaking into fruition for them, making them sad instead of asking if they're sad. So we use visuals, and actually this is 6 years old and being readapted is already insignificant actually. So we're having to readapt it and change some of the visuals on it. But it's our best attempt to do appropriate screening that we're required to do in cancer care, but also try to meet our patients' needs. And most importantly for us, we're working with rural patients who are on the reservation with little technology availability. Cell phone coverage is pretty iffy sometimes. We need to know who their caregivers are, if they even have one. What are other ways we can reach people? Here are some engagement ideas that you may take for granted because in the system, like everybody has a patient portal, but so many people don't know how to use their patient portal. They don't know, they don't have an email, they don't use email, they don't have a computer. How you can even just teach your patients how to use the patient portal. Have a patient portal class. How much time and investment is it for you as a clinic? Pretty little. It's one person, maybe 1 hour. Maybe you can do it by Zoom. Lots of people use Zoom and family members help. We teach our patients how to do Zoom at our cancer clinic so that they can participate in a lot of the support offerings that we offer now because we're still fully not in person after COVID. We have a Medicare 101 class. I do not teach that one, but I do go to it every year. It's taught by one of our 5 financial counselors, advocates that we have, who are amazing they're very amazing at all things Medicare, health insurance related, financials, and it's such a great class. We tell people to bring your friends. It's free. They hold it during open enrollment, so that patients are fully activated to know about the decisions that they're making if they need to change the plan that they're using, if that makes sense. We have a new patient orientation. So any on-treatment patient at New Mexico Cancer Center, and that could be a rheumatology patient. It is more specifically geared towards cancer, but if it's a rheumatology patient who's going to be spending a lot of time in our infusion room and have a lot of symptom management, and they're going to need to know about the system, we make them come to the new patient orientation, where we have about 9 different departments who come in and say who they are, what they do, how they're going to help them. So nobody wants to come to this, I'll tell you. The clinic did not want to create this. This was not easy to do. Nobody wants to take 5 minutes out of their day and time and what they're planning to do. But we've been doing this for a few years now, and everyone's used to stepping out of what they're doing. They come at a specific time. We have like a time wheel, and each person who comes at a very specific time. It's very structured. And the patients don't want to do it, but we make them come, and they're so glad they did because they know what to do if something's happening on a Friday night at 10 p.m. Or is there somebody at the clinic on Saturday? Who do our financial counselors talk in it? I host it. Our infusion room talks. Our radiation department talks. Our genetics department talks. Whatever you need to tell your patient, we involve that in the new patient orientation. If there's something we want them to do or go to, we include it in the information. I forgot to mention the caregiver class. We teach our caregivers about safety at home. We partner with a local organization, Home Care Assistance. We do memory care classes with them for our caregivers who are experiencing memory issues with the patients, so that they have an understanding of what's happening for them, can feel less frustrated about it. And we also teach them home safety, how to lift somebody up from the toilet, how to get them out of bed, what's a better way to get them dressed, so that they feel empowered to help the patient better without harming themselves. We partner with other stakeholders in the community. We don't have contracts with them. We're not paying them to participate. It's mutually beneficial, the things that we do. We have an oncology dietitian we work with. We do not have an oncology dietitian on staff. Many clinics don't in New Mexico. It's one of the areas that we're kind of hurting. So unless a patient is inpatient, it's very difficult to get connected to a dietitian. So we've partnered with a local dietitian who helped us build out a nutrition intervention program. So every new patient who has a cancer diagnosis or a pretty complicated condition gets a nutrition folder with access to an oncology dietitian. We refer them there. We provide space in our clinic to have one-on-one consultations with them. We also partner with Abbott Nutrition, who provides a free oncology dietitian. It's not a consultation, but if they have one-off questions, they can just call and ask a dietitian those questions. And then we provide, it's mostly robust oral intake with high fat, high protein for our patients who are experiencing anorexia during or extreme weight loss. We connect them to attorneys, to a program who helps with free legal information, someone who helps them apply for disability. These are all organizations that provide this assistance for free to cancer patients or to other healthcare providers in the community. And we help them also connect to independent advocates in the community, depending on what organization will help them. Whatever we can do to support them through it, we'll do it. These are a bunch of the different providers and organizations we partner with, and possibilities just to think about, like what would work for you in your clinic or organization. We have the Senior Citizens Law Office, and they have free legal consultations and workshops. They even help people understand their budget, beyond what our financial counselors can do, like their personal budgets, getting into the nitty-gritty of their finances, as well as connect to legal help. We have community food pantries so any patient who is a Presbyterian patient has access to this community food pantry, and they can get weekly fresh food and produce, and we can automatically refer people to that, and we work with our local food bank to do the same for people with a chronic condition. They have more elevated access to help with food insecurity than the general population does. And home care assistants is who we partner with for memory care and home safety tips, helping our caregivers know what to do at home. We use our community health worker partners. If people have health plans that have a community health worker, we make sure we connect with them, bring them in. They're part of the care team too. Grief, unfortunately, making sure our families get connected to grief support, anticipatory grief, and bereavement is really important. And I didn't put a big cannabis leaf up there, but the New Mexico Department of Health, we are active with the New Mexico Department of Health Medical Cannabis Program. We help our patients get medical cannabis. We've been doing it for 6 years. We also make them come to cannabis class and learn how to use it. So they have some direction. And we have a physician who will talk with them about if it's safe for them to use cannabis with the other treatments they're on. There are some contraindications. Not many, but there are some. Mostly we utilize lots of advocates and specialists as part of the care team. Myself, I'm a navigator, our financial counselors, our community health workers. We have social workers who also help. We help our patients go to programs and events where they can access people that we maybe don't have on our team, but we know they'll be able to talk to them for free at that event. And so your engagement interventions look like this. These are your clinical side, seeing your patient as a unique person. What are their needs? What are the needs of their community they're from, that patient population, including their family caregivers, addressing their psychosocial barriers to care. Of course, we could all talk about transportation all day and all the problems surrounding that, but even outside of that, what are the barriers for them that preventing them from coming? Providing accessible programming. How you can have lots of good ideas to help your patients, but is it something they can do? How are they going to get to it? Are you going to how things? Great, we're going to have Zoom support groups. No one knew how to do Zoom. So then we're okay, well, first we're going to have Zoom classes. Now you know how to connect to Zoom. Now we can have Zoom programming. Teaching the patients what they need to know about your clinic. How do you want them to move in the system? What do they need to know about that so that they can be successful in it? instead of feeling like a problem. Like when we have our new patient orientation, we tell our patients repeatedly the whole hour, please call us first. Please call us. You can't call us too many times. Even if you forget the answer to that question, just call back. We really want you to call us first. So they're not calling their primary care for something that you're supposed to be doing, or vice versa. We just are repetitive with that, and kindly repetitive. Giving them tools and education that's meaningful to them, and not just what you think is meaningful. I think that is hard when we're so used to working in healthcare and healthcare speak, translating it over to patients and what means something to them. What do they need to know? And a lot of the things that we do came from our patients' feedback. We wish we'd known this when it started. That's how our new patient orientation was born. So giving them access to advocates and also teach back. What did you hear about this? Tell me how do you get to your portal again? So, and after you tell them how to do it, have them tell it back to you. Then when they're activated, hopefully they have a better sense of well-being. They certainly hopefully won't feel so shy about talking to you in the clinic or asking questions. At least, hopefully there's at least one person in this system that they feel really comfortable with, that they will tell anything to, and that's okay if it's your role they're talking about. We don't care as long as they're communicating, and then your team communicates back like what that area needs to know that the patient's sharing. And then this is going to help improve their overall ability to get through their health condition or meet the things that they need to do to get through their treatment. And it'll help them with follow through too. And it keeps them coming back. We have a survivorship program in our clinic. So when they're all done with treatment, we want them to come back because they have a better sense of stability if they're followed in the same clinic where they receive treatment for a while. And that way, if anything scary comes up for them, they are automatically referred over to an oncology side. And in the end, this improves their overall costs of care in your facilities. So, and now it's Dani.
Thank you, ma'am. Hi, everybody. My name is Dani Alston. I am a patient navigator with radiation oncology at Florida Urology Partners in Tampa, Florida. We have about 30 providers, focusing mostly on urology. I work with the radiation oncologist. We treat every spectrum, all folks. But the majority of the patients that I have the honor of working with are patients who are affected by advanced prostate cancer. And before I dive into that, this photo is of one of my favorite places on earth. It is Weeki Wachee Springs, just about an hour north of Tampa. It is one of the coolest places to go kayaking. I see manatees all the time. There are rumors to be mermaids. I haven't seen a mermaid yet, which I'm very disappointed. So Florida is not just beaches and Disney World. We also have really cool springs. Springs are crystal clear year-round, 72 degrees. It's gorgeous. Back into patient engagement and activation. So like Jess had talked about, she kind of did like the higher program overview. I have the privilege of talking to you a little bit more about what it's like in a specific clinic. So as a patient navigator, how does patient navigation kind of fit into activation and engagement? Well, first, the best thing to do would be to actually answer, what does a patient navigator do? Simply put, navigators identify and address barriers to care. That's a very simple explanation that has a really broad meaning there. And that can mean a lot of different things depending on where you're working. How my navigation program works versus how Jess's works versus how maybe some of yours work are all going to look very different, which is one of the really exciting things about navigation. By identifying and addressing barriers to care, we're able to engage and activate our patients. A cancer diagnosis often makes patients and their loved ones feel helpless and out of control. I got started working in healthcare, very similar-ish like story for Jess. My dad was diagnosed with bladder cancer. Spoiler alert, he is fine. Thank goodness. But I do remember getting that phone call. I was sitting in my driveway. My mom had called and she said, hey, it looks like your dad has cancer. And I know we talked for about another 10, 15 minutes after that. I have no idea what we talked about. That is all I heard. The world stopped, everything shattered. And that was just, and like I said, I wasn't working in healthcare at the time. I was in a completely different field. And so once everything kind of snapped back into reality, I started Googling what is prostate cancer, or I'm sorry, what is bladder cancer, and was completely overwhelmed, scared myself half to death. Thanks, WebMD. And I had no idea what was going on. I went over to my parents' house. My dad, we were just sitting on the couch, just chit-chatting, and he's like, oh, I have a question for the doctor. And he would call the doctor, leave a message. A couple hours later, the doctor called him back. He'd ask this question. Oh, good. Okay. Gets off the phone. 15, 20 minutes later, oh, I have another question. Calls the doctor a couple hours later. Doctor calls him back, answers his question, gets him back. Yes, my dad is that patient. But he felt comfortable enough to be able to call his doctor and get those questions answered and feel that sense of relief. Seeing my dad relieved made me feel relieved, and we ended up having, thankfully, a happy ending to our story. A couple of years later, I became the first navigator in that urology practice. That was not how it meant to happen. I didn't find out until after I'd already gotten the job. But it's just really cool that I now work with the doctor that saved my dad. So it's pretty cool. That openness and that compassionate conversation really helped to build that confidence and that trust with my dad as a patient, with family members, all of us who work with patients. We see this all the time. You know when a patient trusts you and talks and wants to talk to you and ask you questions when they call you 3, 4, 5 times in a week, because they know that they can call you and not worry about being judged. They know that they can call you and you will have space for them. And that's one of the really cool things about being a navigator and working in engagement and activation for our patients, is that we're able to be that person for our patients. The patient is going to be the center of healthcare. Without the patient, none of us would be here. The navigator has that opportunity to be the connection with physicians, specialists, outside resources, family members. We're that teammate, we're that partner, we're right there, part of the team for that multidisciplinary care. So is it really that simple? Does patient navigation help to activate and engage our patients? Yes and no. Yes, it's super simple in that regard, because patient navigators, we identify barriers to care using evidence-based screenings. One of my favorites is the NCCN screening tool. It's very simple, very basic, but it's a great conversation starter for our patients. Even if a patient has on their screening tool, I have no concerns, I'm super happy, I'm not in pain, I don't need anything, that's still a conversation starter, because now I can identify, is that really the case? What are they doing? How can I learn from this? Because I know I am in distress all the time. And just be able to have those conversations, just to make sure that you're opening up that conversation with your patients. And then that allows us to address those barriers, that we can connect our patients with resources and we can support our patients. The no part, barriers, patients can be their own barrier. We all can be our own barrier. How many people have self-sabotage? We don't have to look. I'm one of those people all the time. Patients can also do that, because we have our fight, flight, freeze. Freeze is a big one. So helping your patient kind of move through that to try to get move them toward the right decision for them. Unfortunately, there's been too many times where a patient has been diagnosed with prostate cancer. I work primarily with patients with prostate cancer. They hear that it's a slow-growing disease. I'm not going to worry about it. I'll come back. And then they come back symptomatic, metastatic, meaning that they have the disease has spread, and now they have it in their bone, and it's bony pain, and that is so, so heartbreaking. But we take them back anyway. Let's go. Let's get this taken care of. I'm still a part of your team. Let's keep talking. Families and caregivers can also inadvertently be barriers to care. Maybe a family member doesn't have the same idea of what the patient wants for their treatment. That can be a little bit interesting navigating. Also, staff. I am a patient navigation program of one. And we have over 5,000 patients in our clinic. I work with about 200 patients, and that's still a lot. And we wear multiple hats. So what I'm able to do versus what a fantastic, huge organization like Jess is able to do is a little bit different. So that's part of the reason why those navigation programs look so different. And then also resource availability. The number of resources that are available versus the number of patients that need them are unfortunately very, very skewed. So we have to be able to get creative on how we're able to help our patients. So this is kind of how I approach our patients. Patients get referred to me typically by our radiation oncologist. Our radiation oncologist is our advanced prostate cancer champion within our clinic. So all patients who are diagnosed with prostate cancer see him. Any of our patients that have advanced prostate cancer that will likely need some kind of financial assistance for their oral oncolytics. I will stay off of my soapbox on how expensive medications are. But typically for our patients that have Medicare with the Part D programs, their first bottle of these prescriptions are usually anywhere from $2,500 to $3,000 for that first month, and then about $600 every month after that, which is about a Social Security check. So that is certainly a situation where our patients are deciding, am I going to get treated for cancer or live? So financial assistance is certainly something that we put a very heavy emphasis on in our clinic. And that's where the majority of my patient navigation, engagement, and activation really plays a part. On that first meeting, being referred to by the radiation oncologist, I'll introduce myself. Hi, my name is Dani Alston. I'm a patient navigator, and I work with Dr. whoever referred. My job is to help support our patients in whatever needs they may have. This initial conversation is just that, just a conversation. We're going to see what's going on, and how I can help is going to be very different for every patient. How can I help you? Take a just kind of step. Hey, we've talked about a lot of things over the last couple of weeks, and I know you're probably really overwhelmed. How are you doing? And start that conversation that way. I personally do not dive right into, what do you need? What do you need? We're already super overwhelmed, especially with a cancer diagnosis, which is where we work. I'm sure at other diagnoses, anytime, patients are just scared and they don't even know where to start. So starting kind of on that, kind of diverting off a little bit, maybe a little small talk, and then bringing back to the kind of the meat and potatoes of the conversation you're supposed to have. At that point, we're identifying those potential needs. That's the engagement part. We're having this conversation. We're trying to figure out what's going on. Now we're going to start working on providing some assistance. Some financial assistance tools I can apply on the patient's behalf, and I can take full ownership of it. Others, I can't. The foundations don't want to work with me. They want to work with the patient. So now I'm trying to support and activate our patients and empower them to take that responsibility into their own hands. With a cancer diagnosis, you feel like you're out of control. Nothing is in your control, you're helpless. Now you've given them an opportunity to focus on something that they can easily control, and they have that support, that safety blanket behind them. They know that they can do it. All of us know that when we feel engaged, when we feel empowered, we're on top of the world. because we're badass advocates, if any of you guys saw that discussion earlier today. So we're providing that support. In screening for my patients, every couple of months, I'm checking in their charts to see what do they need, where are they at. With prostate cancer, bone health is something that we're certainly concerned about, as well as breast cancer, I believe bone health is something that we're certainly looking at. Do they qualify for genetic testing? Have we had the topic of discussion of genetic testing? Any kind of restaging, blood work, imagery, overall case management. And this cycle continues as we continue to see our patients. Just to kind of have a little bit of bragging points, our patient navigation program is relatively young. I am the first patient navigator, and I've been working with our radiation oncology team to build this program. We initiated in June of 2020. Since its inception, we've been able to help over 200 patients who require patient assistance who wouldn't be able to undergo their oral oncolytic treatments without some kind of financial assistance. To date, we've been able to secure over $1.6 million in patient assistance, which is something that I'm very proud of. We've worked really hard for that, and I'm so thankful for the opportunity that we've been able to help those patients. Some professional resources and training tools that have helped me. Like I said, I'm the first navigator, and when I first started, my boss was like, hey, do you want to be a navigator? And I was like, sure, what does that do? He's like, help people, have fun. And so I was like, cool, okay. So it's a lot of being able to be self-taught and have that motivation. I think there's a lot of navigators. The more I've talked to, the more I've realized that a lot of us have kind of been put in that position where it's you have that opportunity to really kind of build your own career, which is both terrifying and really exciting. The NCCN distress meter, is it right here? Very simple, very basic, but it's a good starting point, and you're able to, like New Mexico Cancer Center is able to do, to adjust it to what your patient population requires. George Washington Cancer Center has some awesome resources. They have a certificate of completion that you can take that's all about patient navigation. AONN, which is the Academy of Oncology Nurse and Patient Navigators. Jess and I both are very active in that organization. It's a great resource and able to just talk to other navigators. I think the majority of my knowledge has come from just talking to people and sharing resources and having that support group, because as patient navigators and as anybody in the healthcare field, we need to be supported as well. ACCC, the Association of Community Cancer Centers. This is a paid membership, but they do have some really cool resources as well. Triage Cancer is awesome. It's an organization that provides information for both patients and healthcare providers on financial assistance, managing finances, legal care, gets you set up with legal advocates in your state. I cannot speak highly enough about them. And then some patient resources. Fund Finder is put together, or is backed by PAN, which PAN is one of the sponsors here. You can just put in your diagnosis and you're able to find any available funding that is open for Medicare patients. Zero Prostate Cancer is an organization that I work closely with that's able to take on some of that resource management and help patients in ways that I'm unable to help them, either with other additional resources that maybe I'm not available with or knowledgeable on. In Florida, we have a lot of snowbirds, so sometimes I refer to our Zero Prostate Cancer partners for any out-of-state assistance that I just don't have the ability to try to research on. Triage Cancer, certainly. And then Patient Resource. It's a physician editorial that has magazines, and it reads very similar to a magazine for patients that can have a little bit more information about their diagnoses, but also brings in celebrities that also have had those types of cancers. So it just kind of makes it a little bit more relatable. And so it's not something so clinical that you're reading about, which can be very, very overwhelming. And then here's our fantastic, lots of resources slides. Here's Jess and I's contact information, and we welcome questions. You guys are the bomb. I know we're ready for drinks, fiesta.
I do have a question. Jess, you talked about the Navajo. I also come from a state where we are highly populated in Native American. Oklahoma has recently been declared a reservation again. How did you go about learning the Navajo culture, and how that you needed to adapt the screening?
So I'll just repeat your question just for the folks online. The question was, how did I go about knowing what I needed to do to adapt the NCCN distress screening for our Native American populations, and specifically Navajo for where I'm from in Albuquerque. I knew because I work in, I had connections through the New Mexico Cancer Council. So if all states have a cancer council, if you're working with oncology patients in any organization or clinic, you can look to your cancer council for other professionals and healthcare stakeholders to really help you with population health issues, equity, rural health issues. It's a great resource. So I've been involved with the New Mexico Cancer Council since 2014. I had a lot of professional colleagues who were Navajo working in the health field space, started talking about, of course, like other things like colorectal screening, like what are the barriers that communities are experiencing, which brought up our barrier for depression screening. And that is, we're part of the OCM, Oncology Care Model practice, where you were required to do screenings for depression, the PHQ-9, which is an extensive 10-question on depression for any cultural ethnicity. So, and we had to dive into a year-long conversation where we partnered with other Navajo peoples, both in public health or in healthcare, and also patients or from the community who were interested in the conversation, to talk about what would an appropriate screening look like. And it took a year. We had multiple conversations. We held one meeting in Albuquerque and another one in Gallup, New Mexico, where our Gallup clinic is, close to the border of Navajo Nation. And that's how it started. And we're having a second conversation now to redo that screening tool. And that conversation's happening on a bigger level, more nationally, through other Native American organizations or community health workers who work in that space. There's professionals with the AONN who are helping make connections. And yeah, if you need some help, I'm happy to connect you. You're welcome. Any other questions for me? Turn over to Dani.
Awesome.
We don't have any questions on the live chat either, so thank you so much, Jess and Dani, for
having us.
Thank you for staying.
Yeah.
We are going to have a little 30-minute break, and then there's going to be a sponsored happy hour at, I think it's section 8. Is it what is it called? 8 o'clock is what it is. 8 o'clock in the...
I was like, section 8's something different.
Totally. Don't go to section 8. Quarantine 8? I don't know. So 8 o'clock is going to do a happy hour for a couple hours. And then after dinner, any advocates that want to come back to this room, then MAPA will be hosting a nightcap. So advocates only, no industry, come fun, hang out, get a little wild, a little crazy.
It's New Orleans, the Big
I hope you
Easy.
had a good education day.
Thank you.
Yeah,
Thank you.
absolutely.
Thank you.
Thank you.
Who did it, Jess? We just put it together last night.
Wow, are you serious? I was gonna say that was pretty amazing. I watched the live stream and that was you guys. That was that was really good.
Thank you. Dani. Awesome. Thank you. I'm an internet